30s. For Black women, we've always known this statistic in our oncology community that despite not having an incidence as high as white women, our mortality has actually consistently been higher for 5-6 decades. And it wasn't, I think you'd have to go back to the 1970s where the mortality rate was the same as white women. Since that time, it's been about 40% higher. It's just grown into the 1990s and then persistently been 40% higher. And we'll get into a number of reasons why that is the case later on. And what we do know is that those horrible differences and disparities don't have to be. And I hope we get into what we can do and what we should be doing to reduce the disparities that we see in our survival.
Okay. And Dr. Williams, so what age, do we usually find women getting breast cancer? I mean, I know it varies, but on average.
Well, the rate of breast cancer increases after age 50. However, in African American women, we're actually beginning to see more cases younger than that. We're beginning to see cases in women in their 30s and 40s that are higher incidence. And so that's why it's important for a woman to know what her risk for developing breast cancer is. So if one is of average risk, then we would start our screening at age 40. However, if someone is at elevated risk, then we may need to start earlier than that. So it's really important for women to know what their risk is, by age 30, but every woman by age 25 should have some kind of risk assessment to determine what their risk is for developing breast cancer, so that we can then determine if they need to be screened earlier.
Right. So how do we determine who is at high risk and who isn't?
Well, that means having a discussion with one's physician or primary care provider. That person can be sent to a specialist to determine what that risk is. It requires knowing what one's family history is. And that's why I really encourage patients to talk to their family members about what is the family history? Is there a history of breast cancer? And not just breast cancer. Is there a family history of colon cancer, pancreatic cancer, prostate cancer? All of these things are important to helping us to determine if someone is at increased risk. And then we can also determine if someone needs to have genetic testing if we have that information.
Okay. So we're talking about risks right now, right? And so are there other risk factors that put women at higher risk of developing breast cancer?
Right. And there are. So there are what we call risk factors that are modifiable, and then there are risk factors that are non-modifiable that we can't do anything about. Mm-hmm. And some of the main risk factors that for breast cancer are non-modifiable, meaning being a woman increases your risk for breast cancer. A risk for breast cancer in a man is less than 1%, but a lifetime risk for breast cancer in a woman is about 12%. Now, that risk factor increases significantly if you are known to have a mutation that increases your lifetime risk, like a BRCA1 or BRCA2, but there's about 40 variations in a gene now that can have an increased risk for breast cancer. That's why when Robin says know your family history and know it from not just my mother's side and breast cancer or even ovarian cancer, but knowing your family's history, particularly prostate cancer. And the reason why this is so important is there is a change in a gene called BRCA, meaning it was found as a breast cancer gene, but we know it also increases the risk for prostate cancer in men. So having a very strong history of prostate cancer in your family could potentially mean that there might be a change in a gene that has been passed from the father's side down and could increase a woman's risk if she had that gene for developing breast or ovarian cancer. So that's why knowing the full family history, but not just that, knowing if I had a biopsy in the past, what was the result of that biopsy? Was it a type of abnormal proliferation of tissue that we know is not cancer, but is a marker and suggests that the breast tissue is prone to abnormal growth, which can lead to an increased risk over time. So those are higher risk factors. I think we hear more about alcohol consumption, our weight, whether we have diabetes, whether we started our menses early, and whether we had a longer period of menstruation rather than a shorter. Those are all very 1 to 2-fold increase, so much smaller than what we just talked about with previous history of biopsies with proliferative breast tissue, along with a family history that is very strong. And so a first-degree relative is someone that is 1 degree away from you, either your mother, your sister, brother, or your daughter. So having 2 first-degree relatives, that really does increase your risk. When you say my mother had breast cancer and my sister has had breast cancer, so that elevates the risk significantly.
So how do we go about finding out about whether the BRCA gene? What should happen? Who do we see? Who should I send my patients to go do that?
So I'll let Robin, because Robin really deals with a high risk clinic,
Right.
but you just said it, the first step. You are the healthcare provider that will make the referral to Robin.
Mhm.
So our healthcare providers, like yourself, has to take that history and say, okay, when got a woman who has several generations with breast or prostate cancer, I think I just need to refer her to the high risk clinic. And that's what Robin is doing. But Robin, you take it.
Absolutely. And that's how it happens. You refer the patient to me. If you suspect that someone is at elevated risk, especially for breast cancer, then please refer that patient. I will take a history, do a physical exam, and then, I used to do genetic testing actually in my office. Now in a different setting, I actually refer my patients to a genetic counselor. So we have genetic counselors that are part of our team, and then that patient can be sent there to be tested. Testing can be done either using saliva or by drawing blood.
Okay.
And then the genetic counselor will have a very detailed discussion because he or she will draw a pedigree and actually outline the family history, starting from the first degree relatives and going further and all of that information then helps them to determine what the risk is, what might be the best panel to send off for testing.
So I guess the bottom line too is really, as far as me being an intern as primary care, it's about a good history.
It's
right?
about a good history.
Good history.
Yes.
And the other thing is to making sure that your family. I know a lot of times people don't want to talk.
Right.
Well, my mom, she doesn't talk about her history, or my dad, but it's important to get both sides, because you just mentioned earlier, Dr. Hall, about a man in prostate cancer. And if you have a large family history of prostate cancer, that can affect some of the women as far as whether they have the BRCA gene. So getting your family history is so important.
And Dr. Ford, what we know is that there have been historical injustices that have been ongoing in the delivery of healthcare. And so people don't talk about their history because they typically not had the best experience with interacting with the healthcare system. As you know, for men with prostate cancer, back in the 1990s, prior to our great blood tests, the PSA, over 50% of African American men were diagnosed with metastatic disease. At the time, the way we treated metastatic disease to lower the hormone therapy was not anything a man wanted to go home and talk about, you know it. And so that history of just even knowing prostate cancer in the family is difficult to pull out. And that is why we have to just strongly say to our families that, guess what, your mother's history may be your history, may be affecting you. And so everyone is in this together, and we have to be more revealing about our family history, knowing that for many of us, we've wanted to keep it a secret because it wasn't pleasant. But know that you can pass those issues on to your loved ones, and therefore they need to know early if they should be screened earlier. Certainly, we're not sharing in the way that we should.
Right. So you kind of touched on it a little bit earlier about health disparities and how African American women are dying from breast cancer at a higher rate. Can we touch on that a little bit further about why these health disparities are happening and anything that we can do to try to help to improve that?
Yeah.
Well, I was going to say that the screening rates for Black women are actually much better than they were, and actually approaches that of white women. However, the disparity comes in the age of diagnosis for Black women, who tend to be diagnosed at a higher rate of advanced disease. And so, of course, the further along that patient is in their stage, then the more complex it becomes in treatment after considering chemotherapy and other adjuvant treatments. And so the survival rate is impacted by the stage. And so the higher the stage, then the lower the survival. And so it really is important for women to pay attention. If they see changes in their breasts, say something, do something. If it persists, if one isn't quite getting the answer that they expect, because oftentimes I hear women coming to me and saying, well, I've had this lump for a while, and I mentioned it to whomever, and my physician, and they said it was okay. And so, but if there's something wrong, then one has to persist, which is really why it's always good to go when you're concerned about a problem, having an advocate with you, because if you really feel as though something is wrong, then you really do need to be persistent, which is sometimes hard for patients because we trust our providers, although today there's probably less trust than previously. But we trust our providers to give us the best answers. But sometimes we do need to persist a little bit more.
So we're talking, some of the disparities, is it, medical mistrust? Is it the fact that socioeconomic people may not have insurances?
It's multifactorial.
It is. It's everything.
Multifactorial.
So there's a lot that's going on. There's biology. We've got to touch on that. There are social determinants of health. We need to touch on that. There's access to care. We need to touch on that. And then there is the issue that we've also been talking about, which is when primary care providers understand a certain disease one way, but yet it's presenting in a different way. For example, there's an earlier age of onset of breast cancer for Black women. And so if you go to the doctor and you say I have this lump, you do a mammogram, you may have category D or very dense breasts, so the mammogram doesn't pick it up. Your doctor might say, it's nothing. And you know it's different. That's when you have to advocate for yourself, as Robin said, because we do know that many times a primary care physician, because they think about breast cancer as a disease for older women, because there is a about 4 to 5 year median age difference between the diagnosis for Black women and for white women. However, when you get to the age of 40 and younger, there really is just more diagnoses happening with Black women. Well, for a lot of primary care physicians, they haven't gone that deep to even think about, okay, I really need to be diligent. If anyone is coming to me with a family history or they're African American, because this can affect them at an earlier age, they're not thinking that way. They weren't trained that way. So part of that is their ignorance for the differences in onset for different populations. But then we also have to be more diligent and more proactive in advocating for ourselves. And many times, as Robin said, they'll say, oh, your mammogram was fine. You know, you're good. No, you know it's different. You've got to persist, because we've seen this as specialists too many times where the delay in diagnosis has gone on for a year or two because of something like this. But let's also get into biology really quickly, because I don't want to take too much of our group time. There are subtypes of breast cancer. There's hormonally responsive breast cancer. There's HER2 new enriched breast cancer, and there's triple negative breast cancer. And triple negative breast cancer is more common in Black women. We see it in typically about 1 out of 5 versus 1 out of 10 for white women, but it is a more aggressive subtype. And some of our targeted therapies that have really changed the landscape for outcomes for women cannot be used with triple negative breast cancer. It relies on chemotherapy and more recently immunotherapy. But what is really critical to understand is that triple negative breast cancer is also more common in younger Black women. So not only are you getting diagnosed at an age earlier than we see in other ethnic and racial groups, but you're getting diagnosed with a more aggressive histology that requires being able to get diagnosed quickly before it spreads to lymph nodes or has access to the bloodstream and can go to other parts of the body. So that leads to that statement Robin said about more advanced disease that we see at the time of diagnosis. So, you know, about 70 to 75% of white women and Latinos and also Asian women are diagnosed in early stage disease. And that number is about 68% for African American women. So that means, hey, we're getting diagnosed with more lymph node involved disease, more metastatic disease, and it's just harder to treat. And the outcomes are not as good. So we have to be even more diligent about the screening so we can get diagnosed with stage 1, right? Where regardless of race, the survival is over 90%, regardless.
Right. So screening, you know, that's important. Now we're up to screening it, talking about, you know, we've talked about regular risk versus high risk. Now, one of the things I think we had our pre-talk and talking about the recommendation as far as doing self breast exams.
Yeah.
Okay. And I'm not sure if everybody, you know, the recommendation I think that they have out there is that, you know,
self-breast awareness. So they don't want to call it exam. They want to just be aware of your breasts. But how are you aware of your breasts if you're not doing something routinely?
Right.
And this goes back to what we have talked about before, the three of us, and the importance of having adequate representation on clinical trials. There was a clinical trial that was performed, again, not having enough African American women to do what we call a subpopulation analysis. So the outcome was that, oh, self-breast examinations once a month don't seem to increase or improve detection rate. Let's be clear. There are more interval cancers, meaning cancers that are diagnosed between screenings. You get mammogram 1 year, you come back the next year, 6 months after your mammogram, before you're due for your next mammogram, you detect something. That tells us that mammograms aren't perfect. They miss about 20% of breast cancers. We have to know our breasts. So that means, I just say to people, Robin, I'm not sure, you might have a better way. Pick your birth date. Mine is on the 17th of the month. I want to make sure that I'm soaping up in the shower or the bathtub and make sure there's nothing going on in the breast that's different that I feel. It's not going to be painful typically. No swelling underneath the arm, no nipple discharge, no change in contour. Women have to know their breasts because of these interval cancers and the increased rate that we see with Black women.
And what I recommend for women, and I say exactly what Dr. Hall says. How are you going to know your breasts if you don't look, touch, feel, right? And so for postmenopausal women, I do recommend picking a day. Just pick a day, first of the month, middle of the month, your birthday, whatever day, and do that exam. And then also make sure, just like Dr. Hall said, going out to the axilla, because sometimes the lumps will present there first, okay? For premenopausal women, I say to do the breast exam 5 to 7 days after the cycle starts, because that is when the breasts are less lumpy, okay? And so that is the best time for a premenopausal woman to do her self-breast exam.
Excellent, excellent. So definitely, especially we know that young women under 40, they still get breast cancer. And you don't really, we'll get ready to get into when you should do mammogram screenings, but they need something to try to help detect early breast cancer, right?
Right. That's correct.
That's right. And oftentimes these women who are being diagnosed under 40 are being diagnosed because they have a palpable mass.
Palpable mass.
Mm-hmm.
Exactly.
Yes.
So mammograms.
Yeah.
We know mammograms are important as far as screening for breast cancer. And we know there's different societies have different recommendations. Okay. So Dr. Williams, can you kind of lead us into, which we have different societies and what your thoughts are on mammogram?
Yeah, there's the American Cancer Society, there's United States Preventive Task Force, the American Society of Breast Surgeons, NCCN guidelines. So there are a number of guidelines, and most recently, the United States Preventive Task Force actually changed their guidelines, and that was in April of this year. Because their guidelines actually had recommended starting screening at 50. And so they've actually moved their age down. And they were actually recommending every other year.
Which they still do.
Well, they do. And however, the most important part, though, is that they have actually lowered the age of starting. Right. And so right now it is that women between the ages of 40 to 74 should be getting mammography. So starting at age 40 was them actually moving it to age 40 was huge. Okay, because that was not what it was done, had been done before. And the reason that they actually did that was because it was noticed that more women, African American women, were being diagnosed in their 40s, okay, and that Black women were more likely to be diagnosed at a more advanced stage, and then that the mortality rate was much higher for African American women, that we died at a 40% greater rate. The guidelines that I actually tend to follow are those by the NCCN, because I think they are the most straightforward screening guidelines. And so a woman who's at average risk should start, mammography at age 40 and have an annual mammogram. And it's recommended to continue that until your life expectancy, I guess, is less than 10 years. Okay. And that is the most straightforward guideline, I think, to follow. The American Society of Breast Surgeons also recommends starting at 40. It is also recommended that women know what their risk is by age 25. If that patient has a genetic mutation, and we know that by age 25, then that screening will involve getting an annual MRI until age 30. And then at age 30, we would then include mammography as well as the MRI. Okay. And then, for those patients who have an actual genetic mutation, we can talk about prophylactic mastectomies as well. But that conversation doesn't necessarily have to occur like at, age 25, I have a mutation. Okay, I need prophylactic, mastectomies. It doesn't really have to be that way. And we're actually finding that perhaps we don't need to always perform those mastectomies, that we can actually place a patient into screening. But it requires a conversation, right? It's a shared decision-making process. These are the risks. This is your risk for developing a breast cancer, and these are the options for managing it.
Great. Anything to add on to that, Dr. Hall?
Just that the United States Preventive Services Task Force got some of it right, not all of it right. They recognize not only that African American women and Latino women have an earlier age of onset, and that a third of breast cancers are diagnosed before the age of 50. So if we had maintained their previous guidelines, we would have not even offered screening to a third of women before they developed breast cancer. So it was always that starting at the age of 40 still reduce mortality, and mammography screening reduces mortality by 30%. It is a huge reduction. So we know it was good to screen. The only reason that they pushed it back to 50 is they felt that there were too many false positives, meaning that you had callbacks more commonly. We know the callbacks for what turns out to be benign disease it's actually been less since we've improved mammography screening to 3D, in which this is what we really want to talk to you about. You should be thinking about what type of mammogram you want to get and where you're going. And the questions that you should ask are, do you have 3D mammography? Because that's important to ask. Now, most reports that come to you will tell you the density of your breast. And that's important too, because if you have extremely dense breasts, it means two things. One, the mammogram may not be as sensitive, meaning the detection rate can be really low, around 50%. And we want that to be much higher. So then the question that you might have to ask, if they haven't asked you, or had the conversation with you, is should you do more? Should you have more screening done than just the mammogram if you have extremely dense breasts? And by law now, we have to report that out in terms of the breast density. And if it is extremely dense breast, then hey, this mammogram may not have been as effective. Should I have an MRI? Should I have an ultrasound for enhancement? Should I have contrast enhanced digital mammography? So there are essentially 3 other tests that can be offered to help the mammogram because the sensitivity of it isn't what it should be because of the breast tissue.
Okay. So when it reads out you have dense breast, is it the radiologist that recommends that? Is it the fact that as the primary care, we should
Yeah.
just go and
There's
say,
usually,
hey, you should
yeah.
just go on and get a ultrasound, or I guess MRI scan. I mean, how what are you guys' thoughts on that?
It's an education for the primary care physician, um, because the report will come out and it will say the detection or the sensitivity may be less because you have extremely dense breasts, and enhanced screening or additional screening may be recommended.
Mhm.
It does not usually, and Robin, maybe your readouts are different. It usually doesn't tell you what they're going to do. They will have that disclaimer, and then the primary will have to turn around and order it. I think that's an education that needs to occur on the primary side to really start to read that statement and make that next recommendation to the patient. But the reason that's in a report is also full disclosure to the patient that, hey, this test is not as sensitive as it should be, because it's not just that the test isn't as sensitive, but when you have extremely dense breasts, it also means you also have a greater risk of developing a lesion in the breast too. So there's two things that are going on. The detection rate from the mammogram is not as good, but you also have an increased risk of developing breast cancer.
Right. And how, as we all know, insurances play a major role in
Yes.
getting tests. Are you finding that there's pushback from the insurance companies as far as trying to get the MRIs of the breasts?
Not if it's indicated, there is no pushback.
Okay.
And that's why it's important to know what the risk is and to actually calculate that risk. Some imaging centers will actually include in an evaluation of the risk, they'll include like what's called a Tyrcusic score. And then it becomes easier for the primary physician who's ordered that screening mammogram to say, oh, you've got, 25% risk,
Right.
and so I need to send you to a specialist.
Right.
So then it becomes much easier to get that person referred. But there is no pushback. If someone is indicated to have an MRI, then we are able to get it.
Right. And so when you mentioned calculating their risk, so it's important to know that score of over 20% risk.
20% or greater.
Greater.
Yes.
Right.
And there are several calculators. There's the Gale model, there's the Tyrcusic, there's the Black Women's Health risk calculator.
And I like that one because it has prostate cancer history in it too.
Yes, yes.
I think that's important for us, and that's why it's the Black Women's Health calculator, because of it.
And I like the Tyrcusic, and actually, I'm beginning to use both of them.
Yeah.
Right. I'm beginning to use both because I think there are features of both that I really like. I like the detail of the Tyrcusic score, asking for height and weight and density of your mammogram, age of first pregnancy. So there's a lot of detail there, and it also will ask for that family history as well. And so I really like that one, but the Black Women's Health also includes race. And so
everything else you just mentioned.
Right.
Everything else you just mentioned. So it's really pretty thorough, I think. But both of them, Tyrcusic has, I think, always probably been the best one that we've had until recently. Yeah.
Well, that's great. So when now that we know, hey, somebody has a risk score of say 30%, right? So what happens at that point? Did their screenings change?
Well, you have a risk of 30%, then you're high risk.
Right.
And a number of things should be happening. You should see someone like Robin, who will refer you to a genetic counselor. At the least, you should undergo genetic testing and start enhanced screening. Um, and that means you would have had a full understanding of your family history and your previous history of biopsies, as well as any other risk factors. So all of that should occur in a high-risk clinic. And each institution is doing it a little bit differently. Some of the high-risk clinics are in the Women's Imaging Center, and you get it all done right there. Everyone isn't immediately referred to a genetic counselor. They might even do genetic testing, and if it's negative, then implement high-risk screening, but you may not talk to a genetic counselor. So the point is, you need the assessment. Whoever is doing it, someone needs to do that assessment.
Excellent, excellent. Okay, so we know we have mammograms. So now, if the mammogram is abnormal, right? We order the mammogram. The next step is to refer the patient to get the biopsy. Now the biopsy comes back, and now we send it to the breast surgeon. And then where does it go from there? What should the patient expect at that point?
So once the patient comes in, and oftentimes I'm seeing patients when they've already had that diagnosis, they've already had their screening mammogram, diagnostic mammogram, biopsy, whether it's an ultrasound guided core biopsy or what we call a stereotactic biopsy, which is usually done for calcifications in the breast, which are like little white specks that we see on the mammogram. So that patient comes, we review the report. What is the pathology? Is it invasive disease? It could be something just atypical. It could be it could be benign. So let's start there. If it's benign, that's great. We may not need to do anything more than follow-up imaging in about 6 months. And then usually we'll follow that patient out until we see no other changes in the mammogram, that everything is stable, and then get that patient back into screening mammography. If it's something that is atypical, then if it's, let's say, atypical ductal hyperplasia, then we need to have a discussion about having a surgical procedure to remove that area, because if we see atypical ductal hyperplasia, it increases the risk of possible associated invasive disease, right? So that needs to be removed. If it is a ductal carcinoma in situ, there can be multiple discussions that are had. I think traditionally we would remove that area because of the concern about invasive disease being associated with it. However, we look at the grade. Is it a grade 1, grade 2, or grade 3, which is the same we would do for an invasive disease. If it's a ductal carcinoma in situ, there is more thought around watchful surveillance. If it's a small area, if it's low risk, we would talk about hormonal treatment. We would talk about whether or not the patient needs adjuvant radiation. So it can become a very complicated discussion.
Sure.
If it's invasive disease, then once again, and we have algorithms for how we manage patients. Those NCCN guidelines are there to help us in our decision making for when patients are being diagnosed based on the multiple different histologies and the biology of the tumor. If the patient has DCIS, we are looking at the receptors for that DCIS, whether or not it is estrogen sensitive, progesterone sensitive. If someone has invasive disease, we are then also looking at whether or not there is overexpression of the protein called HER2/neu, which Dr. Hall alluded to earlier. And then we go from there. If it's actual invasive disease, it's actually presented at tumor board. So the management of DCIS as well as invasive disease is a collaborative approach. It's a team approach.
Right.
And so that patient will also be referred to a medical oncologist, radiation oncologist. If someone has invasive disease and will need removal of lymph nodes, the patient is sent to occupational therapy. Then we also include our genetic counselor.
I guess one of the things too, for our audience who are not necessarily medically inclined, what about not all women will need to get their full breast removed? Is that correct? Or is that?
That is correct.
Okay, so let's.
That is correct. It depends on what it is.
So this is important. This is important because for a long time there was a disparity in the surgeries that were recommended, and there were more Black women being that were offered mastectomy only and not breast conservation therapy. And breast conservation therapy, which is a two-step procedure where you remove the gross disease in the breast surgically, and then you receive radiation for either a week or 3 weeks now is the typical course after to sterilize the rest of the breast or that area through daily x-ray treatments, shows equivalent outcomes for disease-free survival and local recurrence. In addition, when we look at overall survival, long-term, women who have had breast conservation therapy actually have a higher overall survival rate than women who underwent mastectomy. So you will see nowhere that there is a decrease in outcomes because a woman decided to keep her breast. In fact, if you look at the data long term, there is a survival advantage, and we have thought that it is due to the fact that the radiation is not only sterilizing the breast tissue, but it's sterilizing maybe some microscopic disease that was in lymph nodes that may not have been removed surgically, which is reducing the opportunity for recurrence to occur years later. It is just imperative to go somewhere where you will have your options told to you. Someone is saying your only surgical option is this. It may be right. It may be the only surgical option, but a second opinion is worth it, because you would do in a second opinion for a house. You don't walk into the first house that you see and buy it and say, okay, money down, I'm getting it, unless somehow it's incredible. You don't go to the first car dealership. You usually shop around, and this is your life and your health. So I would always recommend a second opinion when you're talking about having organs removed and major treatments performed, particularly going somewhere that offers clinical trials. Because we know that clinical trials, many times the standard is the latest and the most effective treatment compared to the latest plus something that looks very promising. And we also have data that women and men, Black women and men in particular, who participate on clinical trials have better outcomes. And it has a lot to do with the fact that the staging was all correct and state of the art. The treatment was state of the art and standard. And then you might even have exposure to a very promising treatment. And I know there's many reasons to be very concerned about research, but one of the reasons that our screening guidelines have been off is because we weren't participating in the mammography screening trials. So they based that screening on just white women. And as we've said, I think clearly, we have an earlier age of diagnosis, and now screening recommendations for the whole country were not right for us.
Okay. I know we have a few questions that are going to come up shortly on the screen.
Okay.
But before they come up, we know does everyone need chemotherapy when they have breast cancer?
No, no,
Okay.
not everyone needs
Make sure. 'Cause
chemotherapy.
some people, that's what they think. I'm gonna lose
Right,
my hair. I'm gonna do all of these different things. So
Right.
wanted to
right.
make
Well,
sure.
women who have triple negative breast cancer, yes, they will require chemotherapy as well as immunotherapy. Um, Patients who have HER2 positive disease will require chemotherapy. But if the tumor is hormone receptor positive, HER2 negative, they may or may not require chemotherapy. And that's why we do genomic testing to look more at the behavior of the tumor. How is this tumor going to behave? Because a tumor that is ER/PR positive, HER2 negative, may look as though its overall behavior is not very aggressive, but it actually could be more aggressive than we think. And so that's why it's important to do genomic testing and to also look at the type of genomic testing that is being done.
Okay. I don't know if you guys can see the first question. You can.
Right.
The question says, should you biopsy calcifications?
So all calcifications aren't created equal. And so there are benign calcifications in the breast, and they have a certain characteristic. It's very common to have them. They might be related to blood vessels, they can be related to breast tissue, but they are not of concern. But there are malignant or calcifications, or a category called indeterminate, that may require biopsy because it's unclear why they look the way they do, and it's a specific way in distribution that these calcifications are in the breast tissue and how they're characterized, where a biopsy may be indicated. So I guess the quick answer is no, all calcifications should not be biopsied, but some that look suspicious should be.
Okay. What are some of the insurance barriers, concerns with pre-screening and testing?
I'd like to touch on that one because breast cancer is one of the few malignancies where since now for over 30 years, we have had a program for women to receive a mammogram, get a biopsy, and actually get treatment if they are uninsured. And that is called the Breast and Cervical Early Detection program. It is in all states and in DC. The only issue for that program, for example, where I live, is it starts for women at the age of 35. I think for others, it may be earlier, depending on how your state has implemented the program. But if you come in, you have a strong family history, or you have a concern about your breasts, you can get a mammogram, and you can get a biopsy. And if that biopsy comes back malignant, you are then enrolled onto Medicaid, and you will have insurance. And what is so frustrating about this program is many women don't know it exists across the United States. And we wish we had this program for prostate cancer and colon cancer and for other cancers, but we do have it for this cancer. So there really is no reason why, unless you're younger than that age, for example, in my state, that you don't qualify. But typically, if you go to one of the institutions that have it, because most all big healthcare institutions have this program, because again, it's a federal program. If for some reason you don't qualify, they usually have dollars and a way to still get this done for you.
And what is the name of the program again?
Well, in my state is called Show Me Healthy Women. That's not what you all call it. And it's because we're the Show Me state. It's called the Breast and Cervical Early Detection Program.
Yeah, it's through the CDC.
Yeah. Through the CDC. Okay.
Yeah.
Okay.
And then in DC, they actually have a program called the WISH program. And so,
and that might be it, because they have,
right.
They all name it something different because, again, it goes through the state. But it is a federal program.
Yes.
So that's great information for people to know who need to get the services, uninsured. I'm trying to see if we had any other questions. Yeah. At what age should women start checking for breast cancer?
We typically say, and Robin, please chime in, starting at the age of 2021 is when you should really start to practice self-breast awareness. Again, I think we're pushing on the program that by the age of 25, you should know your risk. So, for example, there are programs in high school now, 9th through 12th grade, just sharing with women, to young ladies, to start knowing about their family history. Go to Thanksgiving's next month, sit around a table and start to learn the health challenges of your relatives, because their health challenges may become your health challenges, and you want to be on top of this. And so just knowing your family history, so that when you start to talk with it's usually an OBGYN, because it's a young woman, or someone who's getting pap smears, you start to tell them your family history, and whether you've had a biopsy in the past for sure, so that you'll know if you're average or high risk, or need to have that referral to determine that.
Yeah, and I agree. By age 20, one should start checking one's breast. And I get, the youngest patient I had was a 19-year-old who was in college, and she had a large breast mass. And she had had a breast mass previously that had been thought to be benign, but it started getting larger. And it turned out to be triple negative. And we did genetic testing, and she was BRCA1 positive. And so once again, highlighting the importance of knowing one's family history, and then women just paying attention to their breast. And I think, last night when we were talking, I had shared with you, there was another family that I had treated, and the patient who was diagnosed with breast cancer was young. She was in her 30s. We did genetic testing. She had a BRCA2 abnormality. There was no breast cancer on the mother's side, right? Her sister got tested. She was BRCA2 positive. So then we tested her dad, and that's where the genetic mutation laid, on the dad's side. And so then he began to pay more attention because of the risk of prostate cancer. And so he began to see someone so that he was getting screened regularly for prostate cancer.
So important. It's all connected.
Yeah, it's all connected.
That's for sure.
And we have to communicate with each other, right? That communication is so key.
Right.
So key.
And I think sometimes we all assume this, but having that family history, that strong family history, and maybe possibly having a genetic variation can really lead to an earlier age of onset of this disease, which is why it's so important to know the family history on both sides and share it with your healthcare provider before the age of 25. That is why it's so important. When you have multiple generations, grandparents, parents, other children who have struggled with this, it's really it's speaking something to you about what might be happening.
Great. So as we get towards the end of the hour, just wanted to get some final words and thoughts from both of you guys, and some take-home points that we can give our listeners.
If you see something, do something. Don't ignore it. Okay. And then there are things that we can do to reduce our risk. We didn't talk about diet. The obesity is a risk factor for breast cancer. So it is really key for us to try to maintain a healthy diet, maintain a healthy weight. Exercise, the CDC actually recommends 30 minutes a day, 5 days a week. Actually, I think there was a study that just came out recently where even walking 11 minutes a day. So it's really doing something. You have to be physically active. Eating plenty of fruits and vegetables, a diet that is high in antioxidants is really important. Obesity is thought to be a chronic, kind of low-grade inflammatory state. And so once again, pointing out that we really do need to pay attention to maintaining our weight, being physically active, having a healthy diet, avoiding alcohol, excessive alcohol, and then avoiding tobacco use. So those are all things that we can do. Those are the modifiable risk factors that we talked about earlier.
But then also, I want us to be positive about this. You know, we really have a beautiful system that works together. We don't think about how amazing our organs are, right? Our kidneys, our body to take in food and extract the good and get the bad out with waste, and the things we need to do to keep it healthy. Sometimes we are just hard on ourselves. I mean, we don't go and just do the regular tune-up, even though our kidneys are just working hard every day, all day long. And I think if we knew how exquisitely beautiful each one of us and our organs are and how you all are out there, you would say, why can't I just do a health check? And so part of this is just remembering just the beauty that we have within ourselves and supporting ourselves and being better to ourselves and remembering our body hears every word we say. So be positive. And if you want to stop cancer, you got to spot it. So cancer starts early. It's usually not screaming at you. It is not painful. So following the screenings, that's why we're here today, to say, you know, we want to keep you beautiful. And the most important thing that we didn't talk about is when we say early stage outcomes are 90% regardless of race, 90% survival, what we also didn't say is that means typically you find it that early, and the majority of women, whether they're Black, white, Asian, or Latino, are going to have a surgery where they can preserve their breast, are going to have radiation that I will recommend usually now at 1 week, may have to go on a pill or not, possibly have to do chemotherapy, but maybe not. So the whole point is you detect these very early, stage 0, precancerous lesion, or stage 1. Stage 0, 99% survival. Stage 1, over 90% regardless of race. You have to do less. You don't have to have treatment for 6 months, you know, because your lymph nodes are involved. So for every reason, go to the doctor and take care of yourself.
Well, I think we had a great talk today on breast cancer. A lot of valuable information was given out. I think that screening, early detection, and not only for breast cancer, but all cancers, yes. Right? So there's multiple cancers that we screen for: colon cancer, right. Prostate cancer, lung cancer. There are screening for lung cancers now.
Right. That's right.
But stop smoking. So
yeah.
Don't get to that point.
Right.
So, but I think that the bottom line is early detection helps save lives. And I'd like to thank both of you today for coming on and giving us all this valuable information. And hopefully we can have you back at another time, maybe for prostate cancer.
Yeah. Oh, that's because it's another one that's very similar. If we can just detect it early, survival is over 99%. That's amazing, right? And that's
so thank you on behalf of Omega Psi Phi Fraternity and Gamma Pi Chapter. We appreciate you guys coming, and guys have a great weekend. Take care.
You too. Thank you for having me.
Thank you very much.
Bye-bye.